Grand. Well, why don't we get started, if that's okay? And I'm sure more friendly faces will arrive in the next few minutes, if that's okay. Lots of you I recognise and know well. For those I don't, my name is David Hope-Jones. I'm the Chief Executive of the Scotland-Malawi Partnership, and welcome to this, our 13th Scotland-Malawi. Apologies. Welcome to our 13th COVID coordination meeting. Our last was on the 25th of January. I'm sure many of you were there. I think we had around 250 or so in total. We had the Malawi Minister for Health, which was wonderful. That also served as a meeting of the Scottish Parliament's cross-party group for Malawi and the UK Parliament's all-party parliamentary group for Malawi. We have since then had a meeting of the Oxygen Supply Coordination Group, which Alberto will tell us more about in a moment, on the 2nd of February, and my thanks to those who took part in that. The aim of this afternoon's meeting is threefold. Firstly, to be updated about the situation in Malawi. It continues to change rapidly. Secondly, to explore some of the key themes that have been identified by our members and priorities identified by our partners in Malawi. And thirdly, as always, as a coordination network, to support networking, coordination, collaboration, and shared learning. On this third point, please do use the chat bar at the bottom of your screen enthusiastically to, if you want to now, introduce yourself and your organisation, to directly reach out to people, to communicate directly. Just remember, if you do have any direct messages on the chat bar, to save that before the end of the meeting, because we're not able to capture those in our records, although we will share all other general public comments in the chat bar. So do consider everything said in this meeting and written in the chat bar as being in the public domain, as we'll make the video available afterwards, as we always do. Our experience so far is that it's fine to have cameras on. We haven't seen that significantly impeding our friends in Malawi to be able to take part, but if anyone does have any significant issues, please do let us know. Please do tweet through the meeting if you want to, if you're that way inclined, using Twitter handle @ScotlandMalawi. Very briefly, the agenda for our meeting has, I suppose, 6 points on it. Firstly, a general briefing from the College of Medicine on the situation in Malawi with regards to COVID. Secondly, a specific look at the reopening of schools, and delighted to have two spokespeople from the Ministry of Education. Malawi's schools went back yesterday, as did the youngest primary school students in Scotland. And if you're noticing that it's slightly quieter at my end than usual, it's because my two young under fives are at nursery. So excuse me if I smile and enjoy the peace through this meeting. We want to get back to this oxygen supply issue, and pleased to have Alberto, the chair of our oxygen supply coordination group, with us. He'll update us. We want to come back to the role of faith groups, and really pleased to have a representative of the CCAP Livingstonia talking through what they're doing up in the north. We want to, as requested at the 25th of January meeting, look at the mental health implications of COVID in Malawi and what's happening in that space. And we want to keep time at the end to allow those who wish to share a little bit about their projects and ongoing work in responding to COVID between Scotland and Malawi. That's quite a lot to get through, as ever, in just 90 minutes. I will do all I can to help us keep to time. If you're a speaker, please don't be offended if you are cut short, or if you don't have as much time as you would have liked. We're keeping almost all of our speakers the sort of 3 to 5 minutes or so. I'll endeavour to give a 30-second warning to you directly in the chat box, but please don't be offended if I have to jump in. Our experience is trying to keep these meetings to 90 minutes is appreciated by everyone. Not least our busy and important colleagues in Malawi who have given time to take part. So I think that's everything I wanted to say in introducing the meeting. And without further delay, I'm very keen to move to item 1, which is the overview of the situation in Malawi. Now, I know it's been a very busy time, understandably, for the College of Medicine, and I just want to check whether Professor Kumwenda is on the line and is able to update us. I know if he is not, there are colleagues I can see Johnstone there. Fantastic. Well, really delighted to introduce Professor Johnstone Kumwenda. He's a Professor of Internal Medicine at the College of Medicine. He's at the forefront of the fight against COVID because he serves as the chairperson of the College of Medicine's COVID response team. Professor, I wonder if I could hand over to you for a general update.
Thank you, David. I hope you can hear me. Yeah, my connection is a little bit dodgy. I'll be as quick as possible. To date, over 30,000 Malawians have tested COVID positive, and we have over 1,000 deaths. And we should know that out of these 30,000, the largest proportion has come over the last 6 to 8 weeks, which is around 23,000 new cases over the last 6 to 8 weeks. And out of the 1,000 deaths, 800 of these have come in the last 6 to 8 weeks. Our positivity rate at one point was at 35%. The latest is 8%, just under 9%, but we know that we are not counting very well in this country, but it's pointing in the right direction in terms of COVID prevention. However, community positivity rate at one point at the 2 health centers where the Wellcome Trust is carrying research was at around 60%. So the 2 health centers of Ndirande and Liwimbi in Bland at one time it was 60%. When I last talked to them last week, they told me the positivity rate. So community transmission seems to be going on. People that have COVID not being tested in the community. A small study that has been carried out at the Queen Elizabeth Hospital has also shown that the case fatality rate amongst pregnant women, especially in the 3rd trimester, seems to be higher than the case fatality rate due to all other comorbid conditions in pregnant women. This to me is concerning. It's a small study, but it needs to be replicated in other places. As I said, testing is very selective. I wish we were able to take on significantly over the last 2 weeks. At one time at Queen Elizabeth Hospital, we had close to 110 patients admitted to our, at the last counting this morning, we had 20 patients, and the average over the last 2 weeks has been between 15 and 20 patients in hospital. One thing that is seem to be younger than what we see in Europe and America. More than half of all our patients are people that have died. This is the snapshot of the COVID situation in Malawi. To answer if I have answers. Thank you.
Professor, thank you very much indeed. I think for some of your excellent talk there, the connection meant that it wasn't possible to hear everything. I suspect that will have been the case for others as well. If it was possible and you're able to send me an email with the text of what was said, I can put that in the chat box and in the notes of the meeting, and that way we can ensure that everyone has all of the right numbers and nothing was missed. But Professor Kumwenda, once again, thank you very much for a very useful update. Now, I'm told Professor Macphesrson Mallewa might also be on the line, the principal of the College of Medicine. and he might be able to say a few words as well. Can I ask Professor Mallewa, Principal, if you're on the line, would you like to say a few words from your perspective?
Good afternoon. This is Mark Mallewa. I just want to thank you, the group, for this well-coordinated effort. I'd like to thank again Professor John Kumwenda for the wonderful presentation, and indeed just join with him in saying we are at the moment seeing fewer cases than before, but this has just been in the last few weeks. But the beginning of January was horrific for Malawi. And I'm just hoping that the trend we are seeing at the moment is the right trend and that indeed it will sustain, but it's too early for us to say anything. But just to say indeed, thank you for your collaborated efforts and we look forward to working with you all. Thank you.
Professor, Principal, thank you very much indeed. I wonder if I could ask if anyone has any questions for either of the College of Medicine professors that we have. Please do type it in the chat box or put up your hand either digitally or in person, and I will endeavour to come to you. Any questions on the general COVID situation in Malawi? Please either write in the chat box or wave your hand virtually or literally. I can see Jane Gebby has a question. Jane, over to you.
I was just wondering if in Malawi there is yet any picture of the influence on morbidity and mortality if you are carrying HIV.
I wonder if either Professor Kumwenda or Professor Mallewa would like to answer that question. While we wait, please do feel free to ask any other questions, to wave your hand virtually, literally, or put it in the chat box. Professor Kumwenda and Mallewa, I'm not sure if you heard the question there from Jane Gebby about HIV/AIDS. Professor Mallewa.
I was waiting for Professor Kumwenda to respond to that. But what we've seen is that there's no correlation between HIV and COVID. And actually, I think I was talking to someone yesterday who says he's seen a reverse correlation between being on ARVs and COVID. But this is anecdotal. I don't think we can make anything out of it. But on the whole, yes, severe immunosuppression, it is comorbidity. It is associated with severe disease, but not if they're under good virological control. Over.
Thank you very much, Principal. And I've received a message. I can see a message there from Professor Kumwenda saying his connectivity, his bandwidth is poor at the moment. So, Principal, maybe a couple more questions if you are happy to field. I can see a question from Jonathan Groves in the chat box. Jonathan, if you are happy to say that out loud.
Yes, hello everyone. The numbers of cases officially recorded in Malawi are obviously very low, certainly compared with what we experience in the West, but we know that testing is very low as well. I wonder, does Malawi have any statistics that it gathers about excess deaths nationally, or is the situation in rural areas really still very unknown? Thank you.
Thank you. Principal, if you're happy to answer that.
Most of the data that we have in Malawi is for the cities, the main cities of Malawi. That's the four: Blantyre, Lilongwe, Mzuzu, and Zomba. But the statistics in the rural Malawi is very scanty, so it's difficult to know whether the figures that we have represent national statistics. Most likely not, because there's not much testing happening in the rural bits of Malawi.
Thank you very much, Principal. I'll take two more questions. The first from Jenny Chinimbiri, then I'll turn to Alistair Wiley. So first, Jenny Chinimbiri, Secretary for Africa, Church of Scotland. Jenny, over to you.
Thanks, David. So my connection's not great, which is why my video's off. I don't know if I misheard, but I think I heard Professor Johnstone speak about the mortality in pregnant women, particularly in their third trimester, being higher. And if I did hear that correctly, I'm wondering if they know why that is.
So thank you for the question. I hope you can hear me.
I can, yes.
Yes, we can.
We actually got this data only this afternoon during our grand round, and we are asking our obstetrics colleagues to try to tease the data further and find out what might be the reasons that might be causing this already compromises respiratory function in the third trimester. And to try to overcome that seems to be a huge difficulty in these women. And proning seems to be another problem if a woman is pregnant. So these were some of the speculative reasons that they gave to us during the presentation.
Thank you very much, Professor. I wonder, I think final question for this section, Alistair Wiley, if you'd like to say your question out loud.
Thank you, Chair, and good afternoon. This is something that's more on the public health and epidemiology rather than clinical side, but I wonder if you might be able to tell us a bit about to what extent there's a contact tracing system developed in Malawi, and connected with that, what measures there are, financial or material, to support people who are being required to self-isolate. Thank you.
Thank you. Either professors would like to answer that?
So there is some contact tracing, but it's not holistic, if I might say so, because of the way the system has been overwhelmed. Testing has been really limited to people coming with symptoms. But during the early phase of January, there was some contact tracing that was being done, but this is not wholesale. Too limited number of human resource that can go on to test households, and further material resources like transport to go and follow up people that have been in contact. That's why our recovery rate in Malawi is very low. If you look at our charts, there are still large numbers of people that are yet to recover from COVID because we cannot follow them up properly.
Thank you very much. I might abuse my chair's prerogative by squeezing in one last question, if I may, and that's just because it's not on the agenda elsewhere, and that's on vaccines. I'd like to ask either of our two professors from the College of Medicine what your assessment of the situation in Malawi is with regards vaccines, both in the sort of short and medium term, and if anything from your perspective that it's useful for Scotland to be doing to help support an equitable and timely distribution of vaccines.
Can I leave that to you, Mark?
Sure. So I happen to be the Malawi Immunizations Technical Advisory Group Chair, and as of now, what the government has put in place is essentially by the end of next week, we should have the first batch of the AstraZeneca vaccine, and it's initially targeted to the frontline healthcare workers. And then after that, it'll be those with comorbidities. And then thereafter, it'll be those after that 65 years or older. It is estimated that by April, 20% of the population of Malawi will have been vaccinated. And predominantly at the moment, we're talking about the AstraZeneca vaccine. And maybe we've been asked to look at the possibility of entertaining the Johnson & Johnson. So that's where we are at the moment. Over.
Fantastic, Principal. Thank you very much indeed. And please do register our eagerness to support Malawi with the rollout of the vaccinations. I know there's key communications work fighting the disinformation in Malawi, as there is in in Scotland, the UK, and sadly around the world. So we do stand in solidarity with our friends in Malawi, and any support we can offer, we are ready to respond quickly. We do need to move on in the agenda, so I'm keen to say once again a very big thank you to Professor Macphesrson Mallewa, the Principal of the College of Medicine, and Professor Johnstone Kumwenda, who chairs the college's COVID response team. Both are, as you can understand, extremely busy, and I've said to both, please do feel free to leave the call and continue their working day. But if either professors would like to stay and perhaps answer on the chat box any of the questions we didn't have time to respond to, that would be most welcome as well. But thank you very much indeed for your time. It's very much appreciated by all in Scotland. And I wonder if I could move on to the second item in our agenda, and this is the reopening of schools in Malawi. My understanding is I think both primary and secondary schools went back yesterday, and we are in regular contact with the Minister for Education in Malawi, Honourable Agnes Nalonje. She herself was a former director of the Malawi-Scotland Partnership. She's lived and worked in Edinburgh and so is integral within the bilateral relationship. And really delighted that we have a senior spokesperson from the Ministry of Education. I'd like to turn to Mr. Raphael Agabu, who's the Director of Quality Assurance in the Ministry of Education. And many of you will know Mr. Agabu. He's been involved with partnerships with Scotland and Education Scotland for many years and is a long-standing friend of the Scotland-Malawi Partnership. Mr. Agabu, are you there?
Yes, David, how are you?
Very well, thank you. We can hear you loud and clear.
Thank you. First of all, let me thank you for inviting the Ministry of Education to participate in this meeting, and that we can also give you some insights into the Malawi. I will speak the primary, secondary teacher education, and even the higher education, because we are handling all those subsectors together. Professor Kumwenda and Professor Mallewa have given the current update on the current statistics. I will not repeat that, but suffice to say that the current and future impact of the COVID situation in Malawi on the education sector is very huge. And March 2020, and we opened in September 2020, and we closed again after reopening in January 2021, and we have just reopened yesterday. Briefly on a government response, we had the national response preparedness plan from March 2020, and the overall objective was to ensure that teaching and learning continues through innovative solutions and creating an enabling environment in which communities with special attention would be given to vulnerable groups. So some frameworks, remote to use like radio, television, and the mobile technology were used, and also some textbooks printed for distribution to those who may not have access to the technologies. The National Planning Commission estimates the total social cost of closing schools would be around $5.2 billion US, which is an equivalent to a loss in income for 6 million children, and they put a very, very huge impact. They look at tertiary and higher education, and for those living in the rural area, to other activities that help them to support their families. For example, engaging in small businesses. For girls, we had a very big impact because girls ventured into early marriages, exploitation, and other viruses. The National Response Plan included ministerial circulars on COVID-19. Discussions between education and documentation and guidelines that would improve the situation in terms of communication for the schools and the students. So mass media campaign ensued to make sure that we kept our students abreast and that they would be coming back to school. The reopening was done in phases in September, particularly September 7, 2020, for those who were in final years of their examinations and final years of their university level. Other classes began in October 2020. And the Minister of Education, Honorable Nyalonje, told a press conference that the reopening of schools aimed at reducing the economic and social impact of coronavirus on the country, as girls and children from poor households were more impacted negatively by the closure of the schools. Education institutions, as I said earlier, opened for the first term of the 2021 academic year on 4th January 2021. Barely 2 weeks after opening, we closed again on the 18th January after seeing that the numbers of COVID cases were rising. And having monitored the situation, as given by the two professors, government decided that schools reopened, colleges reopened yesterday on 22nd February after 5 weeks break. Generally, the guiding principles for reopening of these schools is that we look at the progress made in the monitoring of the fight and management of COVID-19 as guided by health professionals and the Presidential Task Force, with emphasis on strict observance and adherence to health and hygiene guidelines. In this, we look at the balance between the right to life and right to education, equity and inclusion in adherence to guidelines for reopening, and safely with special attention to needs of children with special needs, girls, orphans, the needy, and other vulnerable groups. And another principle is to look at the institutional capacity and readiness to enforce preventive measures so that individual schools are subjected to rapid assessment on how the guidelines for the opening of schools include issues on disinfecting the schools using guidelines which were in collaboration with the Ministry of Health as well as the district councils. All schools are to ensure that hand washing facilities are available and that hand washing is enforced. Training of teachers on COVID-19 preventive measures. Schools to ensure that they observe 1 meter social distance, and all teachers and learners should always wear face masks. So far, challenges that we have encountered in the fight and management of COVID-19 within the school structure is number one, inclusion, gender, and equity. There has been a very big impact on the girl child, in that the girl child and children from poor households, who comprise the majority of the learner population, have been heavily negatively affected. Early marriages, pregnancies have been on the increase. Most young adolescent girls run the risk of dropping out, and learners with special needs have been negatively affected because most of the initiatives provided have not met their needs. Second challenge is the reimagining teaching and learning. The reopening of schools has provided some lessons in that we have a challenge of high pupil-teacher ratio. We have limited capacity for schools to provide school furniture. We have limited the availability of classrooms. And there is also need to rethink about policies regarding recruitment and continuous professional development of teachers. There is need to rethink how to finance the training and recruitment of teachers so that there are more teachers recruited and deployed. Thirdly, the coronavirus has impacted so much on education in such a way that the ministry has been exposed to high teaching and learning. ICT to readily support teaching and learning processes. So the ministry engaged telecommunication infrastructure organizations to support the ministry with internet for learners. Ministry also offered lessons through radio and television. And most learners did not have access to the education opportunity offered just because during the school closure, we had limited access for a majority of our students. For example, statistics are showing that only 16% of Malawians have access to internet, 33% have access to radio, 52% have access to mobile phone, and 14% have access to television. And this is according to National Statistics Office 2019. And you will see from here that we really have had a lot of challenges in making a larger population of our students access teaching and learning during the closure of schools. Let me add also that we've had some successes in the preparation for reopening, that we have managed to think about building low-cost classrooms to increase on a classroom space, provide clean water to all our institutions, increase the number of teachers, more especially in the basic education level, primary, and increase capacity of the ministry to deliver through open mode. In terms of areas of critical need for support right now, I wish to say that we need personal protective equipment and specialized teaching and learning materials for learners with special needs, because this is an area where the ministry is greatly lacking. Most of the initiatives that we've had undertaken are general in nature, but we have a significant number of students at all levels that are special needs students requiring special attention. Chair, I think briefly, let me stop here. Thank you very much.
Mr. Agabu, thank you very much indeed. That was an extremely useful briefing. Thank you. I'm keen to briefly turn to another speaker from the Ministry of Education, who I'll introduce in a moment. While I do, please, can I invite everyone for questions for either of our Ministry of Education's speakers to put them in the chat box. Put them for the attention of everybody rather than a direct question so everyone can see it, but feel free to make clear who your question is to. And if I could invite all of our speakers to help respond on a written basis first to the chat box questions, and that helps us have the core content in the meeting and the questions on the chat box. So please do put your questions in the chat box for either Raphael Agabu or our next speaker, who is from the Department of Special Needs and Inclusive Education within the Ministry of Education. It's Vessium Chikhoza. Vessium, if you can hear me, over to you.
Thank you very much, David. Hello, everybody. My name is Vessium Chikhoza Piri. I work with the Ministry of Education, Department of Special Needs and Inclusive Education. First and foremost, I would like to thank Mr. Agabu for ably putting across some of the issues that I actually wanted to highlight. So this simply has put my work a bit simple, because I'll just go through a few areas that are also pertinent to this discussion. Ladies and gentlemen, as we are all aware, persons with disabilities are most vulnerable group in the event of the COVID-19 pandemic. We are also aware that children with disabilities have had a devastating state due to lack of COVID-19 pandemic messages on the prevention measures. They are also facing challenges to have access to PPEs, since most of them are coming from out of poor families. It is also has been noted that stigma and discrimination has also affected the livelihoods of persons with disabilities, and this also includes our learners both in the primary, secondary, as well as tertiary level, such as teacher training colleges and so on. During this era of COVID-19 has brought negative impact, particularly on children with disabilities, to have access to quality education. And during the school closure, these children usually has been noted that they are isolated, since the majority of these learners with disabilities and special education needs are coming from rural areas. Of course, we have a cross-section of the SNE teachers, specialist teachers who are there to assess and also assist these learners with special education needs. But sometimes it's very difficult for them to track them in their homes because of the mobility challenges. Even in school as well, it is also very difficult because the teaching and learning resources are not really available for them. There is also great need for the community sensitization on the rights of children with disabilities, especially in schools, as well as at home during the COVID-19 pandemic, as well as the provision of the cash transfer especially to those from ultra poor families or households, to take care of these children with disabilities. Now, if we look at the issues that is standing in the issues of COVID-19 pertaining to the children with disabilities and learners with disabilities in the primary, secondary, as well as in higher education, we find that much as we know that those with disabilities and special education needs are in different categories. We have those with hearing problems, the hearing impairment, also those with problems with the sight, vision impairment, and this also includes both the visual, the blind, totally blind, and also those with low vision. But at the same time, there are also learners who are deaf blind, and at the same time also have got those with health impairments, such as those with asthma, respiratory problems, and so on. For example, if you look at those with hearing impairments, it has been noted that it is usually to the mercy of those who are close to them, because there's sometimes there's very little access to information on COVID-19, since even the messages are being put across on radios or TVs. Sometimes they're not able to hear what is being said. We also have got very few interpreters. Whether it is on TV, sometimes we find that certain programs, of course, when they're beamed on TV, there are sign language interpreters, that's okay. But usually it's not always the case with the rest of the other programs on TV. And suffice to say that even on the radios, it's even worse, because people depend on their ears when they are hearing the messages to COVID-19, including those with the special education needs. It is therefore very important that we need to have sign language interpreters, but also there should also be a lot of literature for those with hearing impairments to get through and read for themselves, as well as face shields, so that they are able to lip read what the teachers as well as other people are communicating to them. If you look at those with total blind, the vision impaired, the total blind, and those with low vision, again, is also to the mercy of those who are close to them, because in the issues of keeping social distance, usually it is very difficult for somebody who is blind to know whether is close to an individual or not. This will actually be to the mercy of the one who is sighted to actually move a bit distance, require distance from the one who is totally blind, and also probably explain such kind of issues that it is important for them to keep distance. Ladies and gentlemen, we are also aware that those who are blind, usually they will need to be guided, whether it should be an individual or a colleague guiding them. in most cases, much as we know, usually is through hand guide, which means that it's quite difficult for such students, even when they're in school, to actually keep such kind of distance, because they will have to be guided through hands. And of course, holding one's hand and then moving from one place to another. This is very, very critical, especially in terms when schools are opening, even when schools were not yet open, even in their villages as well, in their homes. The same is also noted, which means that the spread of the COVID-19 can be done very, very easily through that kind of thing. In addition, we have got very limited literature in Braille, and also very limited literature for in large print for those with low vision. This usually causes a threat to the spread of the COVID-19 for students and learners with total blindness, and those with low vision, as well as those with other disabilities as well. Those with health impairments, like for example, those with respiratory problems and those with asthma, again, you find that one of the recommendations that we are supposed to be using the face masks. But then somebody with asthma, a student with asthma, can be much more vulnerable. Hence, therefore, it is very important that you should use the face shields at all times. But suffice to say, on all what I've said, as schools are opening, it is very, very, it has been noted that most of the teachers in the schools have been informed on how they can manage this situation. It has also been found that it has also been noted that these teachers in the resource centers and in the rest of the other schools have been informed to orient the parents of learners, of students with the special education needs, but also to orient the students themselves as the schools are opening, as well as the staff, both the teaching staff as well as the support staff in the schools, on how they can actually give support to students and learners with special education needs in their schools. This is very, very important, because if they are not oriented on how they can be supported, then it will be very, very vulnerable to them actually. Likewise, in schools, we have got boarding schools. For example, in schools which have boarding schools, both primary, secondary, as well as tertiary, we have informed the managers of the schools to make sure that they also help to keep distance of the students from each other, of course, and also making sure that they follow all the measures that have been put across, so that we prevent the further spread of the C-19, especially during this period. I think, as I've said, most of the issues have also been stated by Mr. Agabu, but only to explain just one small point, that we have used the hand sanitizers.
Just 30 seconds, please. Sorry, just in the interest of time, Vessium. Back to you, 30 seconds.
Yes, thank you very much. Yeah, so we are actually recommending that when they are in schools, they should have a lot of hand sanitizers, because for them to be leading somebody who is blind by hand, they will require not only hand washing every time, but hand sanitizers would also do them better. Likewise, the rest of the other students with other disabilities. Otherwise, I'd like to thank you very much. Thank you very much.
Thank you very much indeed, Vessium, Chikhoza. A very, very useful briefing. Thank you. And my apologies, I had to jump in just in managing the timekeeping. There are, I think, 4 excellent questions relating to education and the reopening of schools from Lucy Hannott at Link, Michael Beresford, Zambezi Mission, Susan Flynn, Chifundu, and Gary Bro at CCAP Livingstonia. If I could invite our 2 Ministry of Education speakers, Mr. Agabu and Mr. Chikhoza, if you were able to look through the chat box and answer those questions on the chat box, that would be really, really helpful. But my thanks again to both of you for giving up your time and sharing your expertise and insight on education in Malawi. Moving to the 3rd item in our agenda, I'm keen to come back to an issue that really did come to the top of, I think, all of our minds in that very powerful 25th of January meeting, and that's the supply of oxygen 2 hospitals and medical centres across Malawi. I'm keen to thank our next speaker, Alberto Gregori. He's a consultant orthopaedic surgeon, but he's also stepped up to volunteer his time to chair our Scotland-Malawi Oxygen Coordination Group. And Alberto has been working really all hours of the day and night since the 25th of January to drive forwards our appeal that we launched a week ago, and delighted to hand over to Alberto to update this group on that appeal and what Scots from all sorts of different organisations are doing to support and empower our partners in Malawi to respond to the oxygen supply question. Alberto, over to you.
Thanks very much for that, David. From the 25th of January, yeah, we've been working flat out. I'd love to take this moment just to acknowledge the huge amount of work that Susan Flynn from Chifundu has done in helping collect a lot of the data and working out what was going on. Because part of what we had to do very, very quickly was collect the facts from the coalface, not just from the ministry and the major NGOs, of what was happening on the ground. And we were fortunate in working and attending some of the Oxygen Task Force and health cluster meetings at the Ministry of Health, trying to get a handle of who was doing what. Very early on, it became clear that obviously the big agencies, UNICEF, MSF, were delivering what they had in warehouses on the ground as soon as possible, along with training and ordering materials. But it became clear that materials, if they weren't in the warehouse to be delivered there and then, were not going to arrive till mid-March, which was probably too late for some of the immediate responses. So the group sat and chatted and emailed and WhatsApped, and we determined what was the quickest thing we could do to achieve the best effect for the oxygen crisis, but also mindful of previous work that we had done with World Orthopaedic Concern, that there's an oxygen crisis every day in Malawi, in health centres and hospitals, to provide just the ongoing care for children with pneumonia, pregnant mothers running into difficulty, and patients having emergency surgery. So it was very quickly apparent that the best thing we could do as a relatively small charity was to partner with an initiative by the GCCI, which is actually an academic institution in Malawi, of engineers who are looking at information technology and health management. And they had set up a group of volunteers called Open02, who were going to go and fix oxygen concentrators. They've already done some of that work as part of some projects. And Jerry Douglas, who is the founder of GCCI, isn't able to be with us today, but has asked me to pass on his thanks to what SMP have done. And by partnering with them, it became very clear that they were already in the position, if they had some funds, to start returning the oxygen concentrators that are all over Malawian hospitals that are broken, that aren't maintained, might need a new plug, they might need a new compressor, might need a new valve or zeolite. And if we could repair those, we could actually affect more oxygen being delivered in Malawian hospitals quite quickly. And very much up front, when we launched the appeal, we also personally committed to supporting their first trip out of the capital, Lilongwe, down to Zomba, and they went down and started working in Zomba, repristining oxygen concentrators last week very successfully. And it also became clear, talking to people on the ground, looking at what MSF and Oxfam and the UNICEF were seeing, was that without the ability to measure oxygen concentrations in the clinical setting, basically people were getting too much oxygen, perhaps too soon and for too long, because there was really no idea of what the oxygen concentration being achieved for the patients was. And therefore we were wasting a very important resource. So oxygen monitoring became something we wanted to look at. A complete byproduct of all this engagement was we were able to link up people who had solutions or resources, etc., with other people that needed some resources or needed some help, and identifying some of the issues that happen in any NHS type structure, any government structure, that the message may not percolate from the coalface to the higher echelons of planning in a timeless manner. So we were able to help identify some resources that were there that could be better used, and also the urgency of the need for repair of some of the oxygen concentration plants that existed but were not maintained. So basically the appeal was set up very, very quickly, and David had to sort of respond very, very quickly to get all the bits and pieces in terms of clinical governance, in terms of transparency all sorted. And the appeal has been very, very successful so far, raising some funds, and we've deployed some. I'll go into that in a minute, but very, very briefly, the other aspect that's become very, very clear is that by investing in oxygen concentrator repairs and by investing in oxygen saturation monitoring, which is an essential part of the WHO program for safer surgery, we are also investing in the future of Malawian healthcare. It's not just about a COVID response. Now, we pray that we do not have another COVID wave, but all of these measures will hopefully put us in a better position to deal with a further COVID wave should it arise. The funds that have been raised so far, the appeal has been incredibly successful. So far, we've raised just over £22,000 with some incredibly generous donors, which will be acknowledged by David separately. And we've started to use those already. So we've already purchased an essential material for the function of oxygen concentrators, which when we repair them, we often have to replace a canister, which has basically got the materials that concentrate the oxygen, called zeolite. And we spent just over £5,500 ordering 300 kilos, because the supplies that we have in Open O2 at the moment will probably run out next week. We've funded already the trip down to Zomba, and we're funding the trip up to the northern region, to Mzuzu, to repair oxygen concentrators. And again, we're using the various links that we have on the ground to identify where the broken oxygen concentrators are, try to bring them to one central point, so that it's much easier from the point of view of attending one place, for example, the Mzuzu PAMS centre, with a mobile workshop, and repair them on site. So we spent £5,500 on zeolite. The first batch of oxygen saturation monitors has left via DHL today from MedAid International, who's a community company basically that is involved in developing and working with limit countries and providing healthcare solutions. And we've committed the remaining £7,500 to continuing Open O2's work in returning to the other sites, because obviously we've gone to the big sites, so Lilongwe, Kamuzu Central, we've gone down to Zomba, and we're going up to Mzuzu next week. But there are other hospitals that have 20, 30 concentrators that could do with being repaired, and they will be the second wave, so to speak, of repairs. And it will continue well into the future, because it's much easier to repair an oxygen concentrator. Might cost the donor and the Open O2 about $100, than to order a new one, which is over £1,000 and may not arrive till the end of March now. So it's been very, very valuable doing that. I'd still welcome everybody sharing on their social media platforms and every other way that they have the appeal. Obviously, it's in the Scotsman today. The Royal College of Physicians and Surgeons in Glasgow are going to disseminate it as well. But if anybody in the professional organisations can, please share. Happy to take any questions, but I'm grateful to the huge support we've had in this. Thank you very much.
Thank you very much, Alberto, and as you say, Susan, as well, for the power of work and contacts and on the ground intel that she's brought to that. I really want to flag, it's not just what's been done, but how it's been done and how quickly it's been done that I think is particularly commendable of the Oxygen Coordination Group. It's worked to really listen to Malawi, as Alberto's outlined, to understand the situation on the ground, to look for the most efficient and quick ways of offering that support. And it's done that since the 25th of January in a way that's got everyone's buy-in. The number of emails I've got from clinicians across Malawi and across Scotland saying, fantastic, this is exactly what we should be doing, is genuinely really inspiring. So I'm keen to thank all those involved, and particularly all those who have donated. We wanted to use this meeting first, exactly 1 week since the appeal was launched, to update our stakeholders. And this evening I'll send an email to all, I think 650 of our COVID stakeholders and 1,200 SMP members, updating them on those numbers that Alberto gave there of what's been used so far, what are priorities for the second week. And again, just to re-emphasize this point, it's all about what can be done in the sort of medium term in the next 4 or 5 weeks while Malawi waits for that new kit to arrive. So that's why we, the Scotland-Malawi Partnership, have wasted absolutely no time in making the allocations. We've actually advanced money from our own unrestricted funds to ensure that it happens straight away. So as soon as anyone tells us we're going to donate X quantity of money, immediately we've been able to use that. £22,000 in the first week, and already £22,000 out, doing good. So please do continue to donate, share that piece in the Scotsman today, and really look forward to seeing how that progresses in its next and final week. Please do ask questions, as some of you have started to do, for Alberto. If you just make clear in the chat box your question is for Alberto, and I'm sure he'll heroically go through each of those. Alberto, if you could reply all so everyone can see the answers to the questions, that would be very helpful. But thank you once again to all who have supported that collaborative and coordinated oxygen response effort. I want to turn next in this meeting to look at the role of faith institutions. It's something we've had a couple of specific meetings on last year, looking at the COVID response, and it's hugely important in understanding the crisis in Malawi and understanding the civic response. So I'm really delighted to have a representative of CCAP Livingstonia Synod. It's their health director. It's Mphatso Nguluwe. Mphatso, if you're there, could I hand over to you for maybe four minutes or so, if that's okay?
Thank you very much, David, for having me here. Yeah, the CCAP Synod of Livingstonia continues to be a place of hope and refuge for the people around the catchment area where we are working. The church is working through the hospitals, which are in the hard-to-reach areas in Malawi, and we continue to provide healthcare to the members of the community right in those hard-to-reach areas. The church is working so much on the areas of physical and mental and spiritual health in our catchment area. In the physical, we are working through the hospitals where people are being tested for COVID, and this is when and if the testing kits are available in the areas. Because most of the times, as my colleagues have already said, who spoke before, that our testing is very much selective. It's only people who are very seriously ill, and we want to check if that is COVID. So when the testing kits are available, the hospitals are doing the testing. And again, they are treating the patients. We have isolation centers in some of our hospitals in the northern region, but some don't have the isolation centers, and we have to send the patients to other district hospitals. So it's only certain areas where we can work, we are working with the patients. And we are also working a lot on areas of stigma and discrimination, because the COVID-19 has brought about a lot of stigma and discrimination, not only on the patients, but also the healthcare workers who are dealing with patients. When they have to go out, they are being discriminated against. So those are the areas where the church is working. They have to do that, like in the church, announce on how they can help the hospitals or help the healthcare workers and not discriminate against them. Our biggest challenge has been the limited resources. You know, my colleagues who spoke before have already said about the limited resources that we have. We are not only looking at the material resources, but we are also looking at the staff, because most of our staff have also been affected or infected with COVID. And when these have to go on self-isolation or these have to go on quarantine after working with the patients, they are leaving a gap in the health facilities where they are working. So that affects us a lot in taking care of the patients who are in our facilities. And also areas like having enough oxygen concentrators, having enough PPEs, drugs, and also fuel, because we have to travel a lot for case finding or case tracing. So that affects our budgets a lot, because we need to have a lot of extra than we normally used to have. And also the issue that I talked about before, the issue of stigma and discrimination on our staff, because if our staff are going out there, they are being bullied at times. So that's very hard for us as a faith institution where we need to go out and support people, then we cannot be there because we are being bullied. The priorities that we need to look at the moment is to have enough drugs and supplies. Because if we don't have those and we have patients in our community, in our facilities, we are not able to support them fully on the needs that they have. And also we need to have extra staff. Even if we can have staff who can work on part-time for us, the time that others are either on isolation or they're on quarantine, we need to have extra staff who can help. And also we need to work a lot with the traditional leaders that we can address issues of stigma and discrimination. Those are issues that are coming up and out again and again, so that our staff and all people who have been affected or infected by COVID, they should be able to be handled as any other human beings. And we need a lot of also education around the communities. We have talked on issues of early marriages and early pregnancies. Those in the end, they come back to the hospitals that they need to be taken care of. And there will be a lot of complications when we are having girls who are pregnant and at an early age. So those are the priorities that we need to work on. But to be able to work on all of these, we need to have resources, financially, staff, vehicles, and drugs and other supplies are necessary for us to be able to tackle COVID in a holistic manner. And also to be able to go to the churches and address people that they can understand why we don't need to gather at this time. And the numbers that have been said by the government, most of the people don't understand if you say 50 is all that you need to have in a church. So we need a lot of time to spend with these people that they can understand the situation at the time being. Thank you.
Mphatso Nguluwe, thank you very much indeed for that really useful brief. It's fantastic to hear what the CCAP Livingstonia up in the north is doing. Our congratulations to you and your team on that good work on fighting stigma and discrimination as you describe. We're very lucky to have Mphatso with us, so please do put any questions that you have in the chat box and make clear who it's for. Mphatso, if you're happy to stay on and answer some of those questions in the chat box, again, if you could reply all so everyone could see the answers, that would be really, really helpful, and I know much appreciated by those speakers. But in this, the core video content of the meeting, I want to move us on to our penultimate agenda item. And this is something that's come up, I think, from the last couple of our COVID coordination meetings, and that's the mental health implications of COVID in Malawi. It's something that is talked about a lot in the UK, perhaps less so in Malawi. And I'm really pleased that we've got three fantastic speakers to feed into this space and share us their thoughts. Could I ask each speaker to keep to 3 or 4 minutes or so? And if you're happy to stick around to take questions in the chat box, that would be really appreciated. I wonder if I could turn first to Dr. Olive Liwimbi, who is a psychiatrist at the Zomba Mental Hospital. Olive, can you hear me okay? Over to you, Olive.
Thanks, David. So there have been a number of issues in terms of mental health in Malawi regarding COVID. The first being that there's high levels of fear among the general population, and surprisingly, it's highlighted the importance of mental health. And so for the first time, people are now interested in mental health and actually requesting and looking for more visible mental health services, something which is very new for us. However, because of the increasing amounts of fear, there have been a lot of maladaptive responses as well. So a lot of denial, with people fully knowing that they have COVID, but refusing to test because they are afraid if they are told they've got a positive test, they will die because they're very anxious. They've been reducing numbers of patients seeking care at hospital, knowing fully well they're physically unwell, but because they are afraid that if they go to hospitals, they'll catch COVID. So not staying at home because they are avoiding contact with others, but staying at home, being afraid of hospitals. And then unfortunately, it's also led to delays in seeking care for those with COVID whose symptoms are worsening because they are afraid that they will be killed in hospital. Unfortunately, there's also been increasing levels of fear, increasing levels of frustrations among close family members of patients that have died, and then they end up projecting their frustrations, their fear on health workers, on health infrastructure, even destroying, for example, hospital vehicles if they are told their client died of COVID, because they simply refuse to believe that their clients died of COVID. That's just in general what's been happening around the country. In outpatient services, we've seen increasing numbers of new clients diagnosed with anxiety disorders. We've also seen more patients relapsing, some who were previously stable, but relapsing especially with anxiety disorders. For inpatients, while for the first wave, we only had 3 patients that had COVID, this time when it was at its peak, we had about 88 patients with COVID, and that translated to 35% of the hospital patients having COVID. And that led to a lot of problems. So for example, we only had 1 isolation ward, and then we had to convert the paying ward into a second isolation ward. There were delays in getting results from PCR. Normally it would be 2 days. And with the challenges that we face in terms of instituting COVID preventive measures among our patients, that was a big problem, because at times it would take 7 days to get a result. So transmission was quite high between the patients. But in general, it was a learning experience for us. Although we knew that preventive measures would be difficult to adhere to for clients, this was a real big challenge, because even on the isolation ward, it was a challenge to get patients to wear masks properly, to socially distance themselves. And I won't even talk about attempts at getting them to hand wash. Thanks.
Olive, thank you very much indeed for that picture from Zomba. I wonder if I could turn next to Donncha Mullin, and apologies if I've mispronounced your first name, from the University of Edinburgh. Over to you.
Thanks very much, David. You were very close. No worries. Almost perfect. I hope I'm not too muffled, but I'm in the Royal Infirmary here in Edinburgh. I have to leave my mask on. I'm a psychiatrist with NHSW, and I spent the last year just prior to COVID in Malawi, which is where I met Olive, and that was with the Scotland-Malawi Mental Health Education Project. So what we've done in response to COVID was quite quickly, so June last year was when we brought out a Malawi quick guide to mental health. And this was brought out with the presumption that things like fear, anxiety, and relapsing would be more commonplace with the pandemic, and that Olive has already spoken about so well. The mental health quick guide, I'll post a link to it because it's freely available online as an ebook. But SNEP, we produced it with the support of College of Medicine and University of Malawi, the Ministry of Health there in Malawi, as well as MEHUCA, the patient advocacy group, and St. John of God Hospital in a long way. So it was a very collaborative effort. And the Scottish government funding helped us print thousands of copies and distribute them to over 600 of the clinics around the country. That was all done in June of 2020. And the guide itself is really for frontline staff who may not have experienced much mental health illness or cared for many people with mental illnesses before. So very, very helpful for fundamental support for people who haven't got specialist training. So I think a lot of people would find it useful on the front line. The book itself is being turned into an app, so it can be used on people's phones if they haven't been able to get a hard copy of it, and that will be out in the next couple of months. And around the release of the book, the launch of the book, a group was set up of all the mental health coordinators throughout Malawi, and that was sorted and organised by Owen Wale, who works for SMEP as well as our organisation there. That group still exists. It's a great way of getting information out across the country via WhatsApp to all the key mental health coordinators around the country. Other things SMEP have been doing since the pandemic was a fundraiser. That was an online appeal. It closed in June as well, and raised over £5,000. And that money was given on to Zomba Mental Hospital. It wasn't all necessarily needed in that first wave, but I think that money is coming very handy for getting personal protective equipment and other resources. There's also e-learning, which the Scotland-Malawi Education Project has been running for quite some time, and that's being ramped up in the light of this in order to still provide education to the psychiatry trainees in Malawi, and that's being delivered online. And there's also been some remote marking of coursework because during up to December, the course went ahead in Malawi, but obviously there was no volunteers there, so to help out in person, but we've been able to do some remote marking. So they're the main ways. And again, I'll just reiterate, I'll post a link now to the Malawi Quick Guide for Mental Health, and it's free to download as a PDF. Okay, thanks very much.
Donncha, thank you very, very much indeed, and thank you for being so gracious about my mispronunciation of your name. I think a combination of possibly bandwidth and face mask meant that audibility wasn't great for everyone. I probably got about 70 or 80% of your excellent briefing there. Please do, if you have time, put further updates, key points, and hyperlinks that you mentioned into the chat box. And if you'd like, feel free to email me further notes from what you were saying. We can make sure they're captured accurately in the formal notes of this meeting. We have one more excellent speaker in this section looking at mental health impacts in Malawi. Really delighted to have the Executive Director of the Malawi Health Users and Carers Association, MEHUCA, Thandiwe Mkandwire. Thandiwe, if you can hear me, over to you.
All right, thank you, David. Good afternoon, everyone. Thandiwe, I'm a clinical social worker based in Malawi. I think everything has been covered quite eloquently by the previous speakers. I think I can just add on a little bit. I think in terms of looking to the future, in terms of the impact going forward of COVID on mental health, I think starting with, I think, families of people who've lost someone to COVID-19, I think the impact is going to be quite devastating there, because the fast-paced process of losing a loved one, and then the disruption of mourning rituals. Mourning rituals have been changed, so it's difficult for people to process this loss of a loved one. also considering that some families are losing 2-3 people within the space of days or weeks. So that's going to have quite the impact on the mental health of people. Also, looking at testing of people with COVID-19, there's the fear of getting tested positive. So as Olive said, people do not show up do not go to hospitals to get tested. I think one of the problems is that there's no pre or post counseling of as you go get tested, just to prepare someone for their mental health if they test positive, and how they can manage or how they can cope. So I think that's going to run quite a bit into the future. And as Olive mentioned earlier, that there's been an increase in people asking for mental health services, which is quite a good shift. Sadly, it's come with the pandemic, but we're having more people coming in and asking for mental health services. But the services have been disrupted. Psychosocial support has been disrupted. For instance, with our organization, we've had to suspend our peer support groups and try to adapt into a buddy system. So the services have been disrupted, and as much as people are asking for these services, there's not enough to go around for everybody. So looking towards the future, I think the impact of COVID-19 on mental health is going to be quite devastating. Thank you, David.
Thank you very much indeed, Thandiwe Mkandwire, to Olive and Donncha as well. It is a hugely important area in Malawi, as it is in Scotland. We're very grateful for your briefings there. Please do put any questions you'd like for any of those three spokespeople on mental health implications in Malawi into the chat box, and I'm sure they'll be happy to answer. Again, a reminder, all speakers when replying, please do reply all so everyone can see the answers and benefit from them. We want to end this meeting as we like to, with just an open space for people to be able to share a little bit about what they're up to. Sort of, I suggest maybe 3 minutes per organisation. I have 3 listed so far that have expressed an interest in giving a short update. I could maybe take a sort of a fourth now, and then what I'll do is I'll bring the meeting to a close as close to 2:30 as we can. But I'm not going to go anywhere, and if other people aren't rushing off, just an open space for other people to share if you would like to. But let me start with Medic Malawi, who's been doing fantastic work, and really delighted to have Tom Hunt with us. Tom, over to you.
Yeah, thank you, David. I hope you can hear me live from Malawi. Hopefully the technology's worked. So we work in partnership with St Andrew's Anglican Mission Hospital. And in the last month, we've really got involved in the work at Kasungu District Hospital, where they were pretty overwhelmed almost instantly in the second wave. They rapidly moved from 2 COVID treatment beds in early January to repurpose part of the building to have 8 beds, serving a population of nearly 1 million people across Kasungu district. And the need became really apparent very urgently that oxygen supply was a huge problem. So we launched an appeal about 4 weeks ago, and so far we've brought in between us and some organisations that we work with in the States, we've brought in nearly £40,000 to help with oxygen cylinder supply to start with. And then we've evolved a little bit into, we're on the brink of purchasing 18 10-litre per minute oxygen cylinders, oxygen concentrators to take the pressure off the need for cylinders. So it's been a hectic few weeks, but we've been lucky enough to get some interest from the BBC, who featured us in an article, and the Scotsman newspaper as well. So the response from our supporters and partners has been amazing. Luckily, there's a bit of breathing space at the moment to kind of take stock of how we can best support, in that critical patients have eased a little bit at Kasungu District Hospital. They haven't seen any in the last few days. So it's a good opportunity for us to work in partnership with the DHO and the other doctors there about what the long-term solution is. We all acknowledge, and I think everyone on this group, particularly Alberto and others, that just refilling cylinders is not a long-term solution. So we've got that breathing space at the moment to work with the guys here to try and get these oxygen concentrators in place. The other really exciting thing that we've kind of stumbled across and is in the really early stages is we've been lucky enough to set up a peer-to-peer support network between some doctors in Exeter in the UK, where I come from, and the doctors here offering initially some COVID support, and that will move on to other things as it progresses. And we've got a consultant from the Nightingale in Exeter who's been able to run some specific peer-to-peer support to the doctors here who have really landed in the deep end in the last kind of 2 months with treating COVID. And that's been a really exciting development, being able to offer some skills from the doctors in the UK who've been dealing with this for a year to the doctors here. That's been really encouraging. So thank you, David, for the opportunity to share a little bit about what we're doing, and well done on all the work everyone's doing. Thank you.
Tom, thanks very much indeed. Really impressed with Medic Malawi's work. Really interested as well in those peer-to-peer connections. I'm sure there's probably a lot of people on the call that would be interested in learning a bit more about that. So yeah, any more information that you have, Tom, on that, please do let me know. And anyone on the call, do direct message Tom directly if you want to have a direct conversation about that. But our next update comes from EMS, who are doing fantastic work in Malawi, and really pleased to have Kathy Radcliffe with us for this call. Kathy, over to you.
Thank you, David. Thank you for having me. So EMS is doing quite a lot in Malawi to do with COVID. We've been working on safety and palliative care in all 28 districts in Malawi. PPE for Mulanje Mission Hospital and also Mulanje District Hospital. And also with Mulanje Mission Hospital, we have given them solar power for oxygen, which of course can help with labour and surgery, as well as COVID patients. We're funding a solar-powered pump at Mulanje Mission Hospital for a third borehole, which is new to improve sanitation. And through Mulanje Mission Hospital, we are improving water and sanitation and TB control at 6 government health centres. But mainly what I want to talk about now is our appeal, which is for teenage pregnancy, which is something we've heard quite a bit about in this meeting. And it is, of course, another crisis caused by the pandemic. Because with schools having been closed, people out of work and economic pressure, there's been a sharp rise in pregnancies amongst teenage children under 18s. So obviously that will have repercussions long after the pandemic. So just to give an example of one 15-year-old schoolgirl who is a patient at Mulanje Mission Hospital, her school closed. As she put it, she had nothing to do. She spent more time with her boyfriend. She became pregnant. She considered abortion, which is illegal. She considered suicide, and instead she told her mother, who took her to Mulanje Mission Hospital when she was 3 months pregnant. The girl was counselled, the mother was counselled, and Mulanje Mission Hospital is now supporting the girl through her pregnancy, her birth of the baby, and then also her return to school. So the work that we are raising money for to work with Mulanje Mission Hospital is to do with, I mean, this is a long-standing problem. Even before COVID, in Mulanje district, 32% of adolescent girls became pregnant. 42% of girls in Malawi are married before the age of 18. And this is worse in a pandemic because the schools were closed and there's more transactional sex due to the worsened economic situation. And of course, early pregnancy brings large health risks for the young mother and for her baby. There's also a 12-month compulsory leave from school. And of course, many girls don't go back to school after the birth of their baby. The mother and the baby will have worse health and economic status as a result of this early pregnancy. So the work that we'll be doing with Mulanje Mission Hospital is largely supporting young people to make good choices in the first place. There will be mentoring networks, youth clubs, a girls' conference, youth-friendly health services, improved sex education, community awareness, involvement of community leaders, a transformation of initiation rituals to make them positive, and mentors on sex equality, so involving men and running a boys' conference. And it's really all about giving girls hope in education as well, because we will also pay their school fees and vocational training, get them into that. So our appeal is in Scotland-Malawi Partnership's newsletter. Thank you very much for that. It's also on the EMS website and in our social media. And I'd like to end by saying that we also very much support the Scotland-Malawi Partnership's COVID-19 oxygen appeal, not least because when these girls grow up and decide to have children, they need a hospital with oxygen where they can have their baby safely. Thank you.
Kathy, thank you very much indeed. I'm really keen to sort of commend and help raise awareness of that teenage pregnancy appeal. It's absolutely fantastic and will do a huge amount of good. So please do look at it. As Kathy said, we've got a web page. I'll signpost it to you at the end of the meeting, which has all of the appeals that we know about, but really keen to give that teenage pregnancy appeal a really good push over the next few weeks or so. We have one more speaker in this section. We could probably do one very quick one after that. So if anyone wants to give a quick update on their work, do put up your hand digitally. And I will endeavour to come to you in a moment. But again, I'll then wind up the meeting and there'll be an open space for those who want to stay to be able to talk about anything that you want to talk about. But first, let me hand over to Michael Beresford from the Zambezi Mission, who have been doing fantastic work right since March on COVID response with their local community link. Michael.
Thank you. Yes, I'm the Mission Director for Zambezi Mission, or ZM for short. We work with Malawian churches and Christian organisations as partners, and we support their ministry in a variety of ways. One distinctive aspect of this that's crucial to us is this sense of mutual interdependence that we have, that we share with our partners. Our longest standing partner is the Zambezi Evangelical Church, or ZEC for short, whose roots go back to the start of the mission. ZEC have 5 health centres in rural parts of Malawi. There are 3 in the central region and 2 in the southern region. And since March 2020, our commitment has been to support ZEC's healthcare staff with adequate PPE. We've also supported them with the occasional piece of hardware, such as a new submersible pump this week, when their existing water supply failed after a lightning strike. And we give thanks that thus far, none of ZEC's healthcare staff have been affected by the virus. ZM's also a major supporter of the Evangelical Bible College of Malawi, which is located in Blantyre, and it trains men and women for ministry in a range of evangelical churches. 2020 was a very hard year for the college, with enforced closures compounding existing sustainability challenges. The students had waited at college for 3 weeks from the 18th of January and then were sent home 2 weeks ago. And they're going to, when they come back, they're going to face a very strong challenge to complete the academic year within the originally proposed timescale, which sees this, the 2 semesters finishing in October. Given the late start, this looks a very tall order. There have been other issues as well. For example, we've been trying to complete an income generating scheme at Chifunga near Mwanza to help and support an orphan daycare centre there. It needs a new transformer, but for obvious reasons, Eskom have been struggling with getting supplies in from South Africa. So there in a nutshell is an update from Zambezi Mission. I'd like to take this opportunity to thank the Scotland-Malawi Partnership for their good work, and also for the latest news and information that we get from our friends and co-workers in Malawi through these meetings. Thank you.
Michael, thank you very much indeed, and thank you for each of those who have given an update. I can't see any digital hands raised, so what I'm going to do is say some words of sort of closure and next steps, but if you don't have to rush off, please do stay, and if you turn your video on, I'll know, or if you put a hand up digitally, I'll know that you want to say something. We'll just have a less formal, more open chat, if that's okay. But summarizing what we've heard over the last 90 minutes, thank you to all of our speakers. I think for me in Scotland, there's 2 really important things that we do in responding to COVID-19. The first is to stop and listen. And that's what most of us have done for the last 90 minutes. And I just can't emphasize how important it is. And the second is to work in a coordinated and collaborative way to share what you're doing and to listen to the learning and experience of others. So it's always inspiring to take that time and listen, particularly to our colleagues and counterparts in Malawi. Thank you to Professor Kumwenda and the Principal of the College of Medicine, Professor Mallewa, for their very helpful overarching update. We welcome that the numbers of positive cases has decreased from its peak of 35% to 9%. But as they said, we remain cautiously optimistic, and as we look forwards. It's fantastic that Malawi schools are reopened. My thanks to Raphael Agabu and Vessium Chikhoza for their updates on the situation in Malawi with regards education, and particularly education of those with special or additional needs. We listened to what they've said about the challenges as far as staff, classrooms and PPE. Thank you to Alberto, and behind the scenes to Susan as well, for their leadership since the 25th of January on the oxygen question. I think we can all clap ourselves on the back at the £22,000 that's been raised since this was first broached just 2 weeks or so ago, and all £22,000 out the door and allocated fighting that crisis in Malawi. Wonderful to hear from the CCAP up in the north of Malawi, Mphatso and Nguluwe, to hear what they're doing fighting stigma and discrimination and their work with traditional leaders. Wonderful to have 3 excellent speakers talking about the mental health situation in Malawi. Olive Liwimbi giving us the situation from the Zomba Mental Hospital. Particularly, I thought was striking that the lack of the isolation facilities and the difficulties of social distancing. Donncha Mullin, fantastic to learn more about the Mental Health Quick Guide that's funded by the Scottish Government. And Donncha very kindly put a link to that in the chat box, and we'll have that on the web page associated with this meeting shortly afterwards. And Thandiwe Mkandwire, very good to hear about the impact that is being seen and felt locally, the impact on mental health, impact on those who have lost a relative, as well as the issues around the lack of counselling for those who tested positive. Wonderful to hear from Medic Malawi, Tom Hunt, about what they've done in Kasungu to respond to the second wave, particularly the question of oxygen, and from EMS, Kathy Radcliffe, on their teenage pregnancy appeal, and at the end there, Mike Beresford from Zambezi Mission, which continues to do powerful work. Craig, if you're there, I wonder if you could put the poll up on our screen, and hopefully by magic, my face is hidden by a poll with just 2 very quick, short questions. It's really important that we get this data. Please do just take a moment to give your answers to those 2 short questions. My thanks once again to all of the speakers today. My reminder to help donate to that oxygen appeal, but also share information about it, put it up on social media, share that piece in the Scotsman, get it across your groups, your networks, your organisations. Please do continue to tweet us, as many have through the meeting, using @Scotland-Malawi. A reminder that we have the COVID-19 section of our website. There you can find information about the latest situation in Malawi. My colleague Jade has cleverly found a way of linking the graphs to that webpage, so they appear live on that page. We have information about the Oxygen Coordination Group and who is on that group. We have information about the 22 appeals that we're raising awareness of. So if you've heard reference to an appeal and you're not sure where to find it, check out our website. There's a section on member perspectives, and we're really keen to invite everyone and anyone, particularly in Malawi, to share their perspectives. It could be a blog, it could be a video, it could be an article, but to email it across to my colleague Jade or myself, and we'll put that up on the website to give a sense of the human experience of COVID in Malawi. And finally, you'll remember back in May, we agreed a set of principles of good practice, both for NGOs and community groups, but also for funders in Scotland, supporting our colleagues and friends in Malawi to respond to COVID. I'm keen to remind everyone of those and to continue to share those. Finally, in addition to answering those 2 quick quantitative questions, we are keen for deeper, more qualitative feedback from these meetings. Please don't be shy. Do send me an email of what you would like these meetings to include and to achieve. Everything that you had on today's agenda was requested by either our members or by our partners in Malawi, and will continue to be led by that feedback. I think that's everything that I had to rattle through. With 4 minutes over. As I say, if anyone wants to go, if anyone needs to go now, please do go. And then once people have gone in sort of 30 seconds or so, there'll be an open space for anyone that wants to hang back to be able to just share anything they want. ask for sort of, it can be informal, but maybe sort of 60 or 90-second updates from people so we can hear from as many as possible. But for those of you saying goodbye at this point, thank you for your time and have a good afternoon. Sikoma Kwambiri.
Thank you very much.
Thank you very much, everybody.
Thank you.
Bye-bye. Thank you.
And for those who want to stay, either give me a wave if you want to share something. Fantastic. I can see Angela Mullins was the first to wave. Angela. Oh, no, it was an accidental wave. No worries. Patricio, I'm pretty confident that looks like a bold and intensive wave. So Patricio, over to you.
All right. Thanks a lot, Dave. Mine is just an observation. I've looked at all the presentation and also what we are doing both on the other side. My observation is that we are looking at the issues of the top to the bottom. Unlike areas where I know the community, especially Malawi, you agree with me that there isn't anything that they have gone out to hear their fears, and maybe this is one of the areas where I thought through this meeting, I wanted to encourage our colleagues maybe to have a survey to see how much we can help in, especially with the issue of vaccine that we're going to have. So this is what I wanted to say. Yes, as much as we are talking, maybe we're forgetting especially that population that is vulnerable with these children that we've seen, the teenager pregnancies and what have you. These are some of the indicators that I think we feel there are gaps in terms of us taking the community needs. So my appeal or my observation or my contribution maybe at another time, maybe through what we have on the ground, is maybe to create more or less like a questionnaire that we can just hear from the community and then we can address the needs. So this is one of the items that I wanted to contribute. Thank you so much.
Patricia, that sounds like a fantastic idea, and it'd be great to have that conversation with you. I mean, if you were able to send an email with more of a sense of how that practically could be done. I could see John Chalice had a hand up. John, was that in reply to Patricia's or a different point? Still unmuted at the moment. Just while I wait from John Chalice. Anyone
yes, hello.
Fantastic, John, over to you.
Yes, so it's a different point actually. You're talking about the vaccines. I'm very concerned, or haven't heard anybody say anything about the method of delivering the vaccines. Have we had it confirmed that there are sufficient needles to inject it in the country? Or is that, am I sort of crying wolf when I shouldn't be? But it seems to me that there's two parts to the operation. Not only is there the vaccine itself whenever it comes or whatever it is, but is there sufficient needles to distribute it to the appropriate people? Do you know the answer to that, anybody?
It's a good question. I don't know the answer in the moment. I'll invite anyone that has a sense on it. First, I want to just go back to Patricia and say, I hear you loud and clear, and very keen to take your points forward, and let's continue that conversation. John, it's an excellent question. I was just seeing there, Professor Mallewa is understandably not on the line anymore, but it sounds as if he would be the person to ask that question of. So I'm very happy to just send him an email now and ask that question and get back to everyone sending an email to everyone that contributed to this meeting. But open it up if anyone wants to say anything there. Heather, I'm not sure if you want to come in on the question of needles.
Yeah, it was around the vaccine. I think John's point is extremely important. And it would be really very good if perhaps by the next COVID meeting, we could have someone who is involved in delivery systems from the Ministry of Health in Malawi, because there are loads of things, not just the needle supply, the personnel resource, the transport, the whatever vaccine there is, at least a refrigerated cold chain, if not the low temperatures required by the Pfizer vaccine. And there must be a team developing these ideas in Malawi to be able to cope, even with their first tranche of vaccine is due to go to healthcare professionals, as far as I understand. But when you get to the wider population, then yes, then there must be a strategy being developed, and it would be very helpful, I think, to hear about that, because once we hear about it, then we can know how we can help.
Yeah, absolutely. Well, very happy to make that commitment that our next coordination meeting, COVID coordination meeting at the end of March, let's really prioritize that in the agenda. We did try and have more speakers, more time in today's meeting on the vaccine rollout. We didn't know when we started whether Professor Mallewa was going to be on the line or not. We didn't have anyone else that could reliably talk about the vaccine rollout. I suspect it's because, as you've probably seen in the media, that it's been delayed a week, that they expected to have the first 100,000 of AstraZeneca this week. It's been pushed back, and I think there's a little bit of uncertainty there. But absolutely, let's ask those questions. I'll do it by email, look to get a written answer in the next sort of 48 hours, which I'll share with everyone. But we'll put it on the agenda to be able to look, dig down a bit deeper into some of those issues. Any other input, thoughts, or reflections from anyone else? Sorry, Heather, it looks as if there was another point. Heather, back to you.
Yeah, I did have a separate dimension apart from what John was saying, and that one of the things that actually through the oxygen appeal is an improving link with the Scottish Global Health Collaborative, where there are a number of people within NHS in Scotland who can contribute some of their expertise. And I think one of the really good things, and Alberto referred to this too, how there was the immediate urgent response, how there's the middle term, what can we do to help, but there's also sustainability, which should always be part of what we're thinking about in helping. And I really do hope that we can maintain the impetus to ensure that skills are shared long term in relation to the use and maintenance of all this equipment, which is being brought back into use urgently. That would be a wonderful legacy long term too. Thank you.
Absolutely, looking at that longer range, the maintenance of the kit. I mean, it's something I've been speaking to Alberto a lot about over the last couple of weeks, and I think it's a very sort of telling symptom of some bigger issues at play. You know, why is that this is the case, that there's so many bits of kit right across Malawi that aren't working. It is an nutritional environment, but I think there are systemic issues there as well, and bits about how the sort of global north interacts with the global south. Each of the hospitals is supposed to have PAM officers, physical asset managers. Dept has historically put money into those programs, but the ability to be able to fix that equipment locally is very limited. And I think there's some embarrassment on that point as well. So it's about sensitively building that capacity. And John, I remember probably 10 years ago speaking to you in Career Garden Lodge about exactly that. You know, how do we look at the broken boreholes across Malawi and invest in the little washer that's needed to fix the ones that are there. And I think that's absolutely where we want to be. Katrina, I saw a hand going up there. Katrina, over to you. On mute.
Sorry, it's just on that very point that you've spoken about and that Heather raised. Obviously, I've had recent discussions with Alberto and yourself about that, but I think that it was just to make the point that I think there is a really huge benefit for the longer term healthcare in Malawi when this oxygen concentrator issue is sorted out. I think, you know, I realise that the committee that's working now is working flat out for the COVID thing, but I think the fact that there's a spotlight now on this as an issue is like an absolute godsend, really, for the health service in general. I mean, I've only been working with colleagues in Malawi since 2005, but certainly that's been the biggest pain in the tonsils, because a lot of the anaesthetic colleagues that I work with are equipped to deal with issues with their anaesthetic equipment. They're able to do the repairs, but they don't necessarily have what they need. And when they've set, you know, at risk, well, I mean, there've been lots of issues that I don't need to go into details about right now. I just really wanted to kind of applaud what's going on and just reiterate that point about the great effect that I hope this will have on oxygen as an essential component of healthcare right across the board, but particularly for safer surgery, critical care, safe motherhood, all of the issues that it's so essential for. And, you know, I hope that in a year's time, well, sooner, but I hope in a year's time we can look back at this and maybe, you know, assisted our colleagues in having oxygen available in every hospital in Malawi, and even hopefully right out to the rural clinics. I think it would be just the best ever outcome from the COVID pandemic that we could wish for.
Yeah, absolutely. No, thanks for your message of support there. And again, credit to the way they've done it, listening at the Malawian side. That, you know, 22 grand, I mean, that by the time you've paid to get them in relatively quickly, maybe that would have got about 15 or so concentrators in, that who knows, you know, likely would be broken again in sort of you know, a couple of years or so. So no, really keen to continue investing in that space. John, I saw another hand up. If anyone else wants to feed into this informal discussion, just turn your video on, give us a wave, or give us a digital wave. John, and then I see Stella's got her hand up as well. John, then Stella.
Yes, yes, this oxygen concentrating thing is a very interesting one, because I was working on it a few years ago, and I was there and I was training the local people to repair it, and had all the equipment there for doing it, the vacuum cleaners to get the dust out and all the filters and everything else. And quite honestly, as somebody said earlier, the fault on many of them is something very, very minor. It might simply be a fuse, but I was really frustrated, and I'm still frustrated that while I could train the people and show them to do it, and as you know in Malawi, yes, it won't go any further than that. And it's really the management and the much higher level to take on board this word maintenance, which of course is not a word they have in Malawi. And as you say, this is a longer term issue, but it is frustrating that many of the, not only oxygen concentrators, but other pieces of equipment can be maintained very easily with very little input, provided the management are on board. I get frustrated about generators as well. I mean, most hospitals have an emergency generator. They work perfectly, at least the ones I put in are good, strong ones, but they need to have new filters and they need to have fuel. So it's a whole question of management. And this is the thing which is, I think, I don't know, it's a proverbial thing which is going on and on and on, but how are we going to crack it? I don't know, but I'm hoping that this oxygen issue is going to sort of perhaps be the nut to start other things happening.
Yeah, absolutely. And I'll be keen to say, I think it's also about how, you know, to generalize, the West has interacted with Malawi for much of the last 30 years. I mean, confidentially, one key Malawian partner, you know, said to Alberto in this, when asked, you know, why are there so many broken units? You know, the answer was, well, it's just easier. You know, the Mzungus want to donate, you know, new stuff. So it's easier to ask for a new one than it is to invest in fixing it. So there's complex and nuanced things there. But I can see Stella wants to jump in. Really thrilled to have Stella with us. Stella's my counterpart, the Chief Exec of the Malawi-Scotland Partnership. I think second, possibly third week in post. Delighted to have you with us. Stella, over to you.
Okay. Hi, David. Can you hear me?
Yes, we can.
Okay, thank you so much. Actually, I would like to greatly appreciate the effort that partners are putting in assisting Malawi. We've seen people running around, working very hard to ensure that we have oxygen here in Malawi. But one issue that I want to bring out is in regard to education. As we're doing all this, I see there's a huge gap in terms of infrastructure, that is classroom blocks for our children. We are saying for us to contain the COVID, we need to practice social distance. But if you visit our schools here in Malawi, even just across here in town, you realize that our pupils, they are learning in an environment where they're they're extremely congested. So I don't see any chance of us containing the corona in such situation. So I'm wondering whether we have maybe we have partners who are interested to support us, support other partners here in Malawi in that area, or maybe there's something that we can do after we finish mobilizing for the oxygen. That's what I wanted to say.
Oh, really good points, Stella, and thanks for contributing.
I know maybe we are asking too much. Yeah?
Well, no, there's a number of our members in Scotland that are active on classroom buildings. There's classrooms for Malawi and others, and looking at innovative new building technologies to be a bit more sort of flood resilient as well. But no, I absolutely hear you loud and clear, and that was also very clear from Honourable Agnes Nyalonje, the Education Minister's speech just a few days ago, that challenge around the space in schools, you know, particularly in the rainy season, the lack of tentage. You know, there's money that could buy tentage for schools, but the lack of those materials. So I think it's a very good point. Throw it open if anyone wants to come back on that excellent point from Stella, or any other sort of final points before we bring this informal discussion to a close. Pam, it's wonderful to see you in the market. Where's your market there? Any other final comments before we draw it to a close? No.
I put myself on mute. It's in Chio.
Oh, fantastic.
Yeah.
Wonderful. Good stuff. My colleague Stuart, when he was out in Malawi, did a picture on Instagram or maybe Twitter of some incredibly red, luscious-looking tomatoes, and I think it's one of our highest-scoring tweets. So we judge our social media presence on whether they compete with the quality of a Malawian tomato, and at the moment, very little can match it for colour and vibrancy. Katrina, did you want to come in there? No. Fantastic. Well, let's draw it to a close unless anyone's waving wildly. It's really lovely at the end of a meeting that's so busy and rushed and so many speakers, just to have a moment and a wee chat. Wendy, did you want to say anything there, or no? That's fine. Fantastic. Well, I'll say goodbye at this point. Thanks very much, everyone. Let's keep in contact. I know Zoom's not perfect, but it's great to be able to hear from everyone, and look forward to us meeting in person. Thanks very much again, everyone.